of time. We do have a lot to get through, so I'm going to go ahead and get started. Welcome, everyone. My name is Dr. Brittany Howell, and I am in the Division of Population Health Sciences here at UAA. I teach gerontology courses, among others, and so I'm very excited to have such a large group of interested folks here for our second session on geriatric care. So if we can go ahead and share the slide deck, Spencer, I am going to introduce our excellent speakers for today's session. As a reminder, we do focus on what's called IPE, or interprofessional education, here in our grand rounds. So as we speak about ways that we can all work together in interdisciplinary clinical teams to keep people healthy and aging in their homes, I would like us to just keep that in mind as we go through a couple of the slides for today's session. We're going to have several panelists. Kicking us off will be Dr. Louise Aronson, who is a geriatrician and a writer and a professor of medicine at the University of California, San Francisco. She's also the author of the books that I use in my classes. So I'm very excited to have her here. We have an excellent panel that also includes some local folks. So we have Amy Urbanis, who is our assistant professor of dietetics and nutrition right here at UAA. We have Lindsay Kerr joining us. She is an occupational therapist at Providence, Alaska Medical Center, and also a faculty at Creighton University. And we have Amanda Biggs, assistant professor of social work here at UAA. I am just a facilitator for today's session, and so I'm going to go ahead and turn this over to Dr. Aronson.
Terrific, thank you. I wish I could say I'm glad to be here and I was in Anchorage, but but no. Anyway, I'm glad to be here and be part of this. So I'm going to start by presenting a case, and I specifically chose someone who, at least in my lens and worldview, is young, or young old anyway. Because sometimes when people hear the word geriatrics, and this includes old people, young people, in between people, they think of people who are very, very old or very disabled. And it's increasingly clear as we look at anything, including, death, risk of death from COVID, that you don't just, boom, overnight become old. There's this gradual change, which anybody who's lived to middle age can attest to. And then at some point in your 60s or 70s, you probably are medically, physiologically old, even though you're completely healthy. So I chose that sort of person. I have called her Patricia R., not her real name, so preserving HIPAA. She's 74 years old. She's been married for 35 years. They have no children, but a good marriage. She actually retired during the pandemic from running a nonprofit to help kids get outside and active, because that's what she loves. Her mother is age 98, so they've got family longevity, and lives nearby independently. So her medical history is long and yet pretty benign, with one exception. So she's got osteoarthritis in her spine or hands. And some of you may know that if you do an MRI of anybody over 40, you're going to find osteoarthritis in their spine. And women postmenopausally, almost all of us will have it in our hands. A little, high cholesterol runs in her family. Her dad had it. She had breast cancer in 2008, had chemo and radiation, a bilateral mastectomy, and has done great ever since, no problems. So essentially, called cured. She is hypothyroid, so takes a pill every day, doesn't bother her a bit. She has seasonal allergies, uses a nose spray, and she had a left rotator cuff injury long ago, but she's completely healed from that. So before the current illness, which began last spring, actually, when I'm meeting her, it's sort of late last fall, but I wanted to pick something fairly current. She was really healthy and fit. She's at 5'4", weighed 133 pounds, and for exercise, she was running 2 to 3 miles a day, unless it was like hiking on the weekends with her husband, who's still working very much full time. And she did weights twice a week, and tended to walk where she went. So when I saw her, she had weight loss, pretty much no appetite, bad constipation, which she'd never had previously, nausea, vomiting intermittently. She couldn't really explain a pattern, poor balance, and back pain. Next slide. So the history I got was that she was her usual very healthy self until 6 months earlier. And it's interesting, you will often hear this from people, but she was like, I wasn't old, and now suddenly that I'm sick, I'm old. So chronologically, she was old, but sometimes we equate old with ill health, as opposed to age and risk. So she said I wasn't old, and now suddenly I'm old. She, that first developed headaches, then she had abdominal pain, she had progressive weakness. She was seen because she was like, "What's going on? This is horrible," and because the symptoms kept changing, by her primary many times, by neurology, by GI who did all the scoping, etc., orthopedics, rheumatology, endocrine. She had lost 27 pounds, and she was not a big woman to begin with, and swore she was forcing herself to eat 2,000 calories a day, which is not something, sadly, that any woman at age 74 can do unless they're exercising for many hours a day. So on exam, she was thin, like really, really thin. There was loose skin. You could see that she had recently lost weight and lost it pretty quickly. She had temporal wasting, that thing where it goes in on the sides of your head, which suggests like too much weight loss. Her muscles had normal tone but decreased mass. Like there just wasn't much of them. She had ataxia, so she just couldn't quite locate her body in space or reach for things. Her reflexes were up, and she was kind of she had some rigidity. Her brain was great. Her mood was shockingly good, although she admitted it was totally getting her down, and she was very frustrated. She'd had a million scans and lots of blood tests. So I won't tell you much except for that surprise. She had arthritis in her spine. But basically, like everything was normal. And so if you just walked by and glanced at her, a lot of people would think, ooh, there's a frail older woman. And then what I think her primary had concluded was that she was having anxiety and an eating disorder. He didn't believe she was eating. And the physical decline was just some sort of reaction to pandemic stress and retirement and her just being totally over the top. So that's the case. Thank you. Perfect timing. I thought I would just pause here to talk about what what aging is. It's not a disease, although it is a distinct biological state. There are diseases like progeria where you have really accelerated aging, as in when you're 1 or 2 years old. Um, but it's clearly a distinct state, and it's not necessarily a good one from a biological perspective. So you have decline at the function of cells, physiologic function, so sort of anatomy, physiology. The parts work less well. Some of them get bigger, some of them get smaller, and it's not totally clear what's going on. There are a bunch of theories, and it may be that all of them are true. So there's the wear and tear. Why our knees wear out and our hips wear out, because actually in most of the time there have been humans on the planet Earth. We tended to die like in our 30s or 40s. And now we live on average, depending actually hugely on what state you live in and what your racial background is and how much money you have. Some people live into their 50s, and a lot of people live into their 80s or 90s if they're on the more fortunate end of the spectrum. There is something called programmed change, where it may just be programmed into the cells and the cells start dying off at a certain period of time. And then there's something called cumulative stochastic damage, which is really just the damage from radiation, environmental insults, all sorts of things that hit your cells. Like when people want to take antioxidants, they're trying to combat this. What happens? Well, you have impaired homeostasis, which basically means the ability to adapt to physiological stress. So maybe you're fine, but if you had to, sprint a block, your legs couldn't do it, you couldn't breathe as well, something like that. Or if you get pneumonia, or actually, I'll use a different example. Let's say you get a really bad cold. I don't know if this has ever happened to you, but it's helping to me. I'm healthy, good lungs, etc. Normally, I just run up flights of steps. But if I get a cold and I go up places, I'm like, so if that happens to me and and I decline further in the coming decades, what might happen is that I'll have so much trouble breathing, even sitting or doing my normal activities, that I end up in the hospital. So it's that ability to regulate that changes. And the biggest thing is the increased risk for disease, disability, and death. But here's the thing to think about when we're talking about healthy aging. It occurs at hugely different rates between individuals and populations. So I talked about earlier about your race in the United States and where you live, et cetera. But we see this across the planet as well. And even within countries where some people do so much better than others by a matter of decades. But the other interesting thing is that it happens differently within individuals. So our patient, for example, she's got some arthritis in her hands and her spine. She's got some wear and tear damage, but she hears well, she sees well, she thinks well, her heart beats well because she was running. Um, she has noticed a few other changes, with her bladder, for example, or her ability to sleep. So some parts of her have aged more than others. We think of aging also in people in healthcare as mutable, sort of things we can make better, um, reversible, things we can fix, and inevitable. So we'll sort of see parts of that, but I'll just give you a few clues. Reversible might be if somebody gets really sick and they become frail. With some months of really good rehab and hard effort at exercise, they can regain their prior functional capacity. And okay, great. And so now we're going to talk more specifically about healthy aging. You see the graph on the right there, which shows sort of early life, adult life, and older age. I like to think of that as childhood, adulthood, and elderhood. And where are the dividing lines? This is one of the iffy things. Honestly, I have a nephew who was probably an adult at age 16 or 17, and another one who just turned 26. And, we have our questions. And similarly, some people seem old physiologically earlier than others. One time when I did consults in prison, you could see the guys who had been on the inside for decades had some stuff I usually only see in people in their late 70s or 80s, and they had it in their 50s. And other people who were first time arrested in their 50s or 60s looked like middle-aged people. Anyway, if you look at those two lines on the curve, you can see the range of function and how it goes from ability, but with a little less reserve than they would have had when they were younger, to disability. And the great thing is that we as healthcare providers can often push people from that orange line, which is in the danger zone and below the disability threshold, up towards the functional zone. And doing that is one of the great pleasures of my career and why I love geriatrics, because people, including patients, often assume you can't make things better or there's no point in trying. So not only do you get the benefit of making them better, but the amazement that everybody feels and the pleasure and the gratitude are a real joy. So healthy aging, what do I mean by that? Well, healthy aging is what we use to describe optimal aging. Some people use the word successful aging. I don't like that because eventually it means we all fail, and something that sets up the entire species for failure just doesn't work for me. So I think healthy aging is optimal aging. You're still pretty healthy. You can do everything you want to do. Your brain's working well, your body's working well, you're socially engaged, you're feeling good. You just have a lot of wellness. Can you hit the advance, please? There we go. Then there's usual aging. And that's sort of typical aging. To me, this is a failure of ambition and also a failure to apply evidence-based healthcare. Usual aging involves people, including older people, having a lot of internalized ageism, which we know leads to worse health outcomes, including heart attacks 7.5 years earlier and more dementia markers in your spinal fluid. It's kind of assuming, oh, I'm getting old, there's nothing I can do to make this better. Or I have knee arthritis, so now I'm going to spend a lot of time in my chair, when abundant data shows if you build the muscle on either side of the knee, that knee is going to feel better and function better. So it's kind of this way in which we make old age a self-fulfilling prophecy by saying, oh, there's nothing we can do, so we do nothing, and then it goes badly, and we say, oh, see, there's old age. Hit advance again, please. And then there's biologic aging. And this is the part we truly can't control. It's universal. In America, we like to think, eat your kale and blueberries and you can live forever. Not true. You may have longer period of healthy aging, but eventually we all age and we all die. Next slide, please. The interesting thing about healthy aging is that when we as professionals discuss it, we're thinking about how long do you live and can we keep you from having diseases? And when we talk about social factors, we think about lifestyle, like what are your health behaviors? How much money do you have? Where do you live? How much support do you have? Those are the things in our studies. But when the public thinks about healthy aging, they think about, am I socially engaged? Do I have good perspective on my life? Do I have an awareness of myself? And all of those things, in contrast to what we did, are things that can and do and must and should adapt as we move, not just through the decades of old age, 60s, 70s, 80s, and 100s, but actually from the start of life as we move forward. Their key elements are meaning and connectedness, satisfaction, dignity, adaptation, and resilience. It's a much more powerful approach, and one that acknowledges like you can have major functional changes and still live a life with meaning, with dignity, and with resilience. Next slide, please. So some people in a variety of journals have recently published what healthy aging looks like from sort of a health perspective, a medical care perspective. The part I like about it is that being healthy as you grow much older, because obviously if you're healthy at 85, it's going to look different than healthy at 65, at 45, at 25, even if you're a relatively healthy person throughout, or you're a person with a disability throughout, or you're a person with a chronic illness throughout. So being healthy, to me, this might be a little more wellness than healthy, requires having something worthwhile to do. And this is this crazy thing that we have in our society where, people are so excited to retire. But what we find, and this is worse for men are liable to die in the year after retirement, much more so than if they make it through that first year, things get better. But you need to have that meaning and purpose. You need a reason to get up in the morning. So when people retire, we've got to get them to think, and what's going to make you excited? How are you going to give to the world? What are you going to be spending your time doing? There has to be a good balance of abilities and challenges, and that has to, maybe change over time. People have to be able to secure the appropriate external resources, which might mean help from any one of us in all our professions, or from a bunch of us all at once. And then it seems to correlate pretty well with having certain attitudinal characteristics like positivity. And they know this from studies of centenarians. And now actually there's so many centenarians that they're looking at super centenarians. So you have to live past 105, which frankly for me is impossible to imagine. Anyway, so can you hit advance, please? So this is the chart that's talked about, and there's an article in the American Geriatric Society from last year, which really talks about promoting health, preventing injury, managing chronic conditions is essential for healthy aging, and then optimizing your brain health, your physical health, your mental health, and social engagement, right? Because we know that people of any age who are socially isolated or lonely, it does more damage to them than it does to be obese or have diabetes or to smoke 15 cigarettes a day. It's really damaging. But the thing I like best about this graph is that it's typically medical. So it doesn't cover all of wellness, right? It doesn't really touch on meaning or spirituality or finances or so many of the other things that people need to thrive at all ages. But it's only half of the of the circle. So it's almost like they inadvertently acknowledged that they were doing this narrow medical thing. I think of this as the medical approach. And if we had the full circle of wellness, we would be thinking truly about health and healthcare. Next slide, please. Integrative aging. This is a very new field which borrows both from geriatrics and gerontology and also from integrative medicine, which takes a whole person approach. And it has been defined by some of us as, the clinician as a therapeutic tool. So really, these things I've talked about that for some science people are abstract, like meaning, purpose. How am I supposed to deal with that? Although there are actually studies showing you how to do that. So there's good science behind it, but it makes some people uncomfortable. On the other hand, they'd be uncomfortable if I was doing surgery on them because I'm half blind. So, we all have our strengths and weaknesses. So it draws also from anything that might help, conventional medicine and all its disciplines, alternative medicine, by which people often mean nutritional supports, mind-body practices. It can be traditions from other cultures, which are so important to patients. And if we can't talk about them, then they're just not going to be telling us what's going on. It's science-based. It focuses as much on prevention and treatment. So I think that is one of the key differences between conventional medicine and integrative aging, and frankly, between geriatrics and integrative aging. The field of geriatrics has traditionally said, well, there aren't enough of us, and so we're going to focus on the oldest and frailest. And that's terrific. I love taking care of old and frail people. I love the cognitive challenge. I love who they are as humans. I love helping. But what most people want rather than good care, or in addition to really good care, is to delay the point where they need that degree of care for as long as possible. And that's where integrative aging really starts paying attention to people in their 60s, if not earlier, to think about what can you do now so that you can have a much longer health span, the years in which you're healthy, a health span that is almost the same length as your lifespan. Because what we have now is people have a health span and then they have years of chronic disease and debility prior to dying. So their health span is significantly shorter than their lifespan. And this approach is to bring those two things together. It's also a life stage approach that acknowledges that what your priorities are if you're in your late 60s are probably different than your mother's in her early 90s. Health and wellness emphasis across functional stages. We'll talk about that more at the end today. An emphasis on self-care. So this is another thing that happens often in geriatric care and in medical care, is that we infantilize people. We are paternalistic towards them. We figure, oh, we're the experts, we're coming to help. And because society strips older people of their agency anyway, assuming like, oh, you should just sit there. Oh, you should rest. Oh, that's too hard for you. You don't do it. Or, oh, I can do that so much more quickly. I'm going to do it. This really is trying to empower the person to participate in their own care, because we know health outcomes are better when the person is invested in their own life and care. It does something else really important, because older people are the people most consistently harmed by medical care. Adverse drug effects, harms of surgery and medicines. Why is that? Because older people have not been included in trials of medications and procedures that are then done to them, actually, and sometimes done to them in larger numbers. And so it's an explicit focus on the needs, challenges, and opportunities of aging and old age. And if you can hit the advance, you will see the wellness wheel. So it really is bigger than that half graph I showed you before, which was a very medical and conventional approach, thinking about all the things that influence health. So I think of wellness as related to health, and medicine as related to your physiology. Next slide, please. I just wanted to point out for the naysayers that actually we almost without exception, there is international data on this. People are happier as they move into elderhood. They are less anxious, and their life satisfaction goes up. Anybody in the sandwich generation will be hoping this is true. Next slide, please. So in conventional medicine, we think about disease, disability, discomfort, dependency, and death. Next, advance, please. And in geriatrics, we often talk about the 5 M's. So I think you're going to have to click you can just click them all. Thank you. What matters? So what are the person's priorities and goals for their life? Medications, mobility, mentation, and multi-morbidity. Next slide. And the integrative aging brings in the 5 Ps. Who is this person and where are they in their life and in the world? Let's think about prevention that is primary, secondary, not just tertiary after they're already sick. Really consider their person-specific priorities. Focus on their ability to adapt and be resilient, and making sure they have purpose, meaning, and quality of life. Next slide, please. So I just wanted to, you can click advance, show you this picture from the New York Post. This is Anna, age 85. She was so bent over from, she was so kyphotic from, they thought osteoporosis, arthritis, etc., that she had to stop driving. She was in constant pain. And this is her dancing at a grandchild's wedding. Next slide, please. She then started doing yoga. Had a physical therapist doing some training here. She did TRX, she did yoga, and hit the next button, please. And this is her standing fully upright. She started driving again. This is at age 85. This is what happens under one of 2 circumstances. When the care team understands how much can be done in older ages, it just is a little more slow, or if the person has enough money to pay for it themselves. It shouldn't be that way. Everyone should have access to this. Next slide. So we're going to talk about interdisciplinary team care for the patient I introduced earlier, the 74-year-old woman with a whole lot of strange symptoms and huge rapid decline over 6 months. All these different people you see on the slide could be relevant. Notably, when she was a healthy, functional 74-year-old, she could go see a doctor, but she couldn't get help from much of anybody else. I mean, yes, if her rotator cuff was acutely hurt, she could be sent to physical therapy. So the interdisciplinary team comes in when people have injuries or illnesses or big declines. And so that's why our current patient is sick. Next slide, please. The role of the physician in geriatric care, I have kind of highlighted as I've talked through this already. We know we start as internists or family physicians, and then we subspecialize. So we know about adults, but we really know a lot more about the different presentations of diseases in old people, about things that happen with age, so only happen to older people, and the harms of our adultist research apparatus and hospitals that routinely harm older adults, look at the data on harm older adults, and go about business as usual. So we have expertise increasingly in healthy aging, always in multi-morbidity, having lots of problems, complexity, serious illness, end of life care. One of the things I love about it is that it's all of life that I get to see, all within older people. A life stage approach, we focus a lot on function and wellness. So it's not just where's the lesion in your brain, but who are you? What do you need to do? And if you've had a stroke, how can we help you do what matters most to you, despite the fact that you can't use your right arm? I know you don't care that I know where the lesion is in your brain. So I think a lot of this I already talked about. We also are very much members of teams, because when we care for, unless we're caring for somebody who is truly healthy aging, geriatrics, as we like to say, is a team sport. It's also fun because you get medical science, geroscience, gerotechnology, which is a huge area in Silicon Valley near me. And then I think that a big purpose of ours is to combat medical ageism. And with that, I believe I turn it over to the next speaker, and I'll see you all later.
Great, thank you, Dr. Aronson. Wow, that's pretty hard to follow. So my name's Amy. I am a registered dietitian and love working with the aging population. And hold on one second, my view just changed and I can't see anybody. Oops, give me 2 seconds. I don't know how to speak just to myself, so I need to be able to see your faces. So anyways, it's okay. So I'm just here to talk a little bit about the role of the registered dietitian. And I was so happy, Dr. Aronson just hit very briefly there for a second about access to a lot of team members and the interdisciplinary team, a couple other colleagues that are going to be speaking here as well. Dietitians are very accessible if you are in a rehab unit, if you're in the hospital, if you're in long-term care, but otherwise, Medicare and most insurance companies don't like to cover seeing a registered dietitian unless you have diabetes or renal disease. So again, a lot of times folks are coming to us already struggling with their chronic disease and really not, not having access to assistance for that healthy aging process and looking at prevention. So I'm really happy that you hit on that. So anyway, so I think that one of the things that I just want everybody to know is that the overall nutrition goal for the aging population is really more about maintenance of health and quality of life. So when you are in your programs, whether that's nursing or what have you, a lot of times you'll get a lot of education talking about the diet and different diet orders and all of these prescriptive and restrictive types of meal plans and things to help with certain conditions somebody might be struggling with. And that is all wonderful. And that's a part of our care plan that we kind of work in. But one of the biggest things that we need to think about is just quality of life and that maintenance of health moving forward. So dietitians, we work with the interdisciplinary team really to establish patient-centered goals. We need to make sure that that our meal plans are meeting the health and nutritional needs of our patients and clients, but also enhance quality of life. So food is a part of all of us, right? I mean, how many of you have already, it's Friday, you might have already been thinking about where you're going tonight or what you might be having, or maybe you prepare a special meal with family. Dr. Aronson, you said you already fed everybody. We have, we celebrate life, we celebrate death with food. We have traditions and we celebrate holidays with food. So we really, although we want to help people meet their nutritional needs, one of my goals is to make sure that people are having the opportunity to love their food and experience and be a part of those types of experiences. So also with that interdisciplinary team, it's really important that we are really communicating with the team. So like I mentioned, registered dietitians can be found in acute care settings, ambulatory settings, and long-term care, and so on and so forth. And some of those places, we have access to our interdisciplinary team where we have, I might be able to be in rounds in a rehab unit, and it's great because I can really work on those goals and we can come up with a care plan that we're all on the same page. But if I'm working in a clinic, in the outpatient setting, kind of by myself, we really have to make sure that all of us, so no matter what type of healthcare professional you're studying to become, that you are really communicating with your team. So you are all on the same page. As dietitians, we follow something called the nutrition care process. Most specialties, most fields have something that's very similar, where I train my students. We do assessment, diagnosis, intervention, and monitoring and evaluation. And so that looks a certain way for the younger population, from peds to just, to adulthood, middle age. But as we are working with folks, really over 50, I start to kind of change how I approach things. Then that kind of over 60, I know Dr. Aronson, you were talking about how, it does get a little wishy-washy with ages. We like to, have these cutoffs, but it does change a little bit. And I really take a much more individualized approach to assessment and counseling. And it's really important that dietitians and all healthcare professionals are treating older adults as unique individuals. One of the reasons why I like working with older adults so much is life experience, right? Every time I work with somebody, I learn something myself. And so we need to be really excellent listeners because older adults have so much to say. And many times they can help you, come up with a plan and help you solve the problems that you are trying to figure out. So all older adults are just unique individuals and should be treated as such and with respect. And then there are many age-related nutrition challenges that we also look at and address through our nutrition care process. Next slide. So I thought I'd just kind of focus on two of those components, the assessment and intervention, and just give you kind of an idea of the types of things that a dietitian would be looking at or considering. So I put up here food and nutrition related history. So that is something that we as dietitians do. We do a lot of talking. My children say I talk too much. I say it makes me good at what I do. So one of the advantages of being a dietitian is that we a lot of times have a lot of time with our patients. So many times I can have an hour appointment just in a counseling session to really get to know my client, my patients, and just do a lot of interviewing and talking and getting to know somebody. And by asking lots of open-ended questions and listening to their life story and how their regular day goes, yes, as it pertains to food and nutrition, but many times I can learn so much about that person and maybe some of the things that they're struggling with, some of their barriers, some of the successes, some of this, I can learn more about the support system. And then a lot of times that is information that I can communicate. I might not do anything with it, but I can communicate to the physician or the social worker or the therapist or whoever might be on my team. We are very much looking for meal patterns. A lot of times older adults might only eat once a day. They might skip meals. They might have wonky sleep patterns and their food is kind of all over the place. I'm very much looking at social factors. So food insecurity, financial barriers, transportation barriers are all part of whether somebody is has a good and adequate diet. Food insecurity is huge. 1 in 14 seniors over the age of 60 are food insecure. And sadly, 1 in 11 people who are between the ages of 50 to 59 are food insecure. So many times we talked about polypharmacy in the last grand rounds. A lot of times people are, kind of grappling. They're on a fixed income and they're trying to decide whether to have, to pay for food or their medicines, and they need to see their physician. So there are lots of those types of things. Psychosocial factors. So Dr. Aronson hit on that idea of social isolation, food and mealtime. People do not eat very well when they eat alone. And we know that. So congregate meals, and if we can find those other supports for people to be able to have to be able to eat with others is a very good thing. I know I'm running out of time. So, and the other thing is malnutrition. So malnutrition is huge among the senior population. And it is something that as dietitians, we really take a strong look at, because we know that health outcomes, hospital stays, hospital admissions, all are worse when people are malnourished. People can also be just undernourished, so doing some good screening and really trying to capture somebody that might be malnourished. So when Dr. Aronson was talking about her patient case that had, very fast, rapid weight loss, the temporal wasting, these are types of things that registered dietitians can participate in and try to identify people that might be malnourished. I also want to just highlight really quickly that overweight and obese adults can be malnourished. And so just because of somebody's size, they might look like they're well nourished does not mean that they're nourished on the inside. Okay, next slide. And so just quickly looking at our intervention and our care plan as a registered dietitian, we really want to make sure that the meal plan is very individualized. We focus on nutrient density. Okay, so we want foods to be, what people are eating, we want them to be super high quality and have a lot of nutritional value in what they're having. We definitely want to liberalize meal plans as much as possible. It is not a time to have a restrictive diet. I've worked with lots of clients who come to me and they're like, my cardiologist wants me to do this. My endocrinologist wants me to do this for diabetes. I'm supposed to, not have any salt. I'm supposed to limit my carbs. I'm supposed to be low fat, eat lots of vegetables, but I don't have any money, like all of these things. And they just feel frustrated. And so a lot of times what happens is you end up eating a bowl of cereal. And if you eat a bowl of cereal twice a day and that's what you eat, you are not going to be well nourished and healthy on the inside. So we need to liberalize these diets. It's kind of ridiculous, actually. Strengthen that social support at any way that we can, and then address those social concerns and provide resources through working with our interdisciplinary team. Thank you. Next person.
Hi, everyone. So I have the role of trying to describe to you what an occupational therapist does. We're a very broad therapy, so sometimes it can be confusing and hard to explain, so I'll do my best. So we are a client-centered health profession. We're very holistic. We promote health and well-being through occupation, and in the senior population and the older adults, we get a lot of, well, I'm retired, I don't need a job. But occupation is just anything that we do. So some of you are students, some of us are working. Those are your occupations as well. Just the fact that you got up and got dressed this morning is an occupation. So we really want people to be able to participate in activities of everyday life, the things that they want to do, have to do, need to do. We also work kind of in communities as well. I work acute care, so I don't get a lot of community engagement. And then we are kind of the MacGyvers of the medical field. We come up with ways to help people do regardless of environment or maybe deficits that they have. So we do a lot of modifying. And like I said, mentioned, we exist in a lot of settings. We work from, people will say, from birth to death. And we are in acute care. We do outpatient, we do skilled nursing facilities, home health. I've also worked in community facilities. And then we are experts in activity analysis. So that is the ability to break down a task and say, okay, you need to put on your shoes. Here are the steps that need to be done. So if you think about it, you have to be able to bend over. You have to be able to tie your shoes. You have to be able to put your foot into your shoe. So maybe you can't do that. Are you able to lift your foot up and cross your foot on your knee? Maybe you wear slip-on shoes. Maybe you need a shoehorn. So that's what we tend to look at is, what is the task at hand? What are the things that you can or can't do? And how can we make it so that you can? You go to the next slide, please. So I wanted to kind of talk about what I would do for our case study. I'm sorry, I forgot her name. Is it Patricia? And I would walk in, and we usually, the first day, we do a lot of talking. We do some movement. I'm looking at what was her previous level of function. This was a very functional, independent woman. So I would know, I would ask her about her home setup. I would ask her about, I know you're retired. What are some things that you do day to day? Who takes care of the house chores? Who does the grocery shopping? What are your roles at home? What are your habits? What do you like to do? And then we'd look at her home. Does she have stairs that she needs to get up and down? What's her bathroom setup like? Do you have support at home? And I know her husband's working, so is there someone that if you needed help that could help you? We look at just general abilities to move. So we look at her ability to do range of motion. Can she move her arms? Can she move her legs? What's her strength like? And then we look at her ability to transfer. Is she able to get out of bed and then go sit in a recliner chair? Is she able to get out of bed and go to the toilet? We'll look at, how is she walking? Does she need a walker? Is she balanced? We'll look at balance as well, just being able to sit and being able to stand. We'll actually take a peek at how she does performing tasks. So can you put these socks on for me? Can you get up and use the toilet? We'll look at coordination if it's relevant. We'll ask about pain. I tend to do a cognitive screen just to determine, are they going to need written directions as well as my verbally telling them about the education I'm giving. And then we'll specialize it and kind of individualize it based on a diagnosis. So I don't kind of dwell on a diagnosis. I look more at the person, but the fact that if I know someone's had a stroke, it gives me an idea of what else I need to look at versus if someone's coming in with a fall at home where they just passed out. Next slide, please. And then the intervention part is, of course, my favorite part. After we do that assessment, the first day, we talk about what are your goals? And usually my question, I work in acute care, so usually my question is, what do you need to be able to safely do to go home? Because that's most people is what they want to do, is they want to go home. And some people will pick, I want to do everything. I don't want anyone to help me with anything. And we have some people that will say, well, I'd rather someone come clean my house for me once a week so I can instead have the energy to go for a hike with my friends on Saturdays. So we let them kind of guide what they want to do. And then there's usually a few things that I know that they have to do. So if someone has stairs, I know that we need to get them up those stairs. If someone has a tub and they have to get into that tub, I know that that's something I need to address. So it's a partnership of what do they want to work on, and then what do they need to work on. And some of the techniques that we use are restoration, modification, compensation, and acquisition. So I'll just kind of give the example of her goal is to get into the shower safely. So when I asked her about her shower, she used to step into a tub, no seat. So we would look at, maybe she can't step into the tub right now, she's weak. So I might offer a solution of, let's do some strengthening. That's a restoration. We want to bring you back to your previous level of health or ability. And then modifications are sometimes a temporary fix for while we're strengthening still. And that might be that we say, let's take a seat. I'm going to give you a seat for your shower, sit down to shower. So when you can save some energy, it'll reduce your risk of falling. Compensation is similar to modification, but she has a history of a rotator cuff injury. She may not be able to use one hand as well as the other. So it might be that, okay, you can't lift both hands up to shower, so maybe you're going to use one hand instead. Or we might give an adaptive equipment, like a long-handled comb if she couldn't reach. And then acquisition is just new skills. So maybe adding adaptive equipment to help, put shoes on, like a long-handled shoe horn, or teaching some new strategies to achieve the task that she wants to do. So we address specific skills. So like her strength, we address body functions. So maybe she is not flexible enough to bend over. Maybe she's got some tight hips. So we could do some stretching there to address body functions. And then we also will look at the whole occupation. So if she says to me, I want to be able to get in the shower completely by myself, I'm going to have her practice getting into the tub. I'm going to have her practice taking a shower. And then my ultimate goal is to help her return to as close to her previous level of function as possible. And if that isn't possible, we're going to work together to get her to a level that she is satisfied with. So quality of life is definitely a big piece of my job and my role as an OT. So that is what I have. Thank you.
Hello, everyone. I'm Amanda, and I want to talk about the role of a social worker on the team today. So I'll just start off in general. A social worker on integrated care team may take on a variety of roles or maybe just one specific role. And I think it really depends on how many other team members you have available. And thinking about our discussion today, we've heard from a variety of different team members who really could contribute a lot in that comprehensive assessment. But just talking a little bit about some of these roles, a social worker is often an advocate. And that's a really common role for a social worker that may overlap with many other roles. So advocating for individuals to obtain what they need. And, we learn about what they need through that assessment. Care management. Care management is a very common role a social worker may take on in an integrative care setting in regards to, individuals who are aging And a care manager really does manage, manages the care, really assesses all of the needs of a person. And, on a spectrum, and I'll go over that a little bit more on the next slide, but much like the wheel that we saw earlier, with all of the different components of our lives. So really assessing all of those areas and then advocating for the individual to obtain, what they want and what they need. Often a social worker on the team may act as a mediator. The social worker may mediate between other professionals on the team or maybe between family members. Sometimes individuals have a different idea of how they would like to age than maybe their children do, or other individuals in their lives, or maybe then even their physician or other professionals on their team. So the social worker may say, hey, let's get together, have a care conference, and really talk about what the person wants, and then try to come to an agreement about how to support them in their autonomy and agency. A social worker may act as a counselor, a clinician in that setting, whether that would be just, helping somebody manage anxiety, depression, a variety of other clinical diagnoses, maybe working with families who are experiencing, or receiving hospice care and need support through that process. Discharge planning is a role social workers do as well. Whether that be discharging from, a hospital, or maybe a long-term care facility or a rehab facility where, somebody may have had a stroke, they go to a rehab facility for 6 months, and now a social worker can assist with planning. What's the next step? Does the person need support still? Do they need an assisted living home? Are there family members that can assist, or are they able to return to living alone or independent? So those are just a handful of the roles that I was thinking about when thinking about working with an aging individual and their families. But I really focused on, facilitating healthy aging, healthy and integrated aging. We really do need to complete that comprehensive assessment, much like, the other team members described. Each of our professions has a version of an assessment so that we can really understand what the person wants and needs. And that way we can, look into our resource bank and try to provide ideas, resources, and support. So big part of that, especially in a care manager role or advocate role, is understanding what the recommendations of the other team members are. So thinking about what the occupational therapist has said, the dietitian, of course, the physician or other specialists, what do they recommend? And then the social worker can say, okay, this is the nutrition plan. Let's really make sure that we can help you get these foods, get you access to these foods that your nutritionist has recommended on an ongoing basis. So really just focusing on maintaining independence, enhancing and maintaining quality of life, and following the lead of the individual. And I think Dr. Aronson talked about that, as well as the other team members. It's really important for us to make sure that we always respect agency and autonomy of the individual, and be careful about the ageism. That is a very common occurrence. And Dr. Aronson touched upon that. And we always have to think about, just because somebody may be on paper a certain age, or they may have certain diagnoses, we can't assume what they want or need based on that. So really hearing from them about what they want for their own life. Next slide, please. So some considerations to make, and these are just really general considerations. And as we talk about these, we can think about Patricia R. and what, some of these considerations, would apply to her situation. Obviously, medical status. And, through our social work education, we always want to make sure that clinicians, counselors, acute mental health facilities always assess or request assessment of somebody's medical status. What is going on medically? Because it may eliminate or change the plan of care drastically if somebody has a brain tumor or something else going on that's affecting their behavior. So what is the person's medical status? Have they had a recent medical workup? Do they have ongoing medical care? Cognitive status is, of course, an important consideration. Now, thinking about Patricia R., we were told that she is cognitively intact, which is wonderful. And we know her medical status. There's, some concerning changes that she's been experiencing lately, and her primary care, physician believes anxiety, eating disorder, dealing with difficult life transitions. So we do have that information. Functional abilities. When we have our occupational therapist on the team, that's amazing because, they can really assess the functional abilities of the person. So, for Patricia R., we were able to hear from Lindsay about, what the assessment would look at, what kind of needs, getting in and out of the shower, et cetera. A lot of times where a social worker could step in there is finding grants or other resources to support, whether that be, the shower chair. Perhaps the person doesn't have the money for that. So could the social worker find a loan closet where they could obtain that? So that's where a social worker could assist there, continuing to look, down this list, looking at the person's abilities to complete daily activities, looking at their social support network. What type of informal supports do they have? Do they have recreational opportunities? Do they have spiritual needs that are not being met in spiritual care? What is their financial status? Do they need support? Do they need benefits, financial benefits that the social worker could assist with? Legal, do they have a power of attorney, a living will? Have they made plans for the future? Estate planning, again, what kinds of plans have they made? So, my final sentence here is just planning for the future and understanding our present situation sets us up for success in aging healthily. We need to make sure that we put plans in place so we don't have to worry about it. Once we get those powers of attorney and things, then we can rest and enjoy our lives and focus on nutrition and other, exercise and social engagement, et cetera. That is just a little bit of what, I would look at working with Patricia R. or other individuals who are aging. I think I'm out of time, but thank you so much, everyone.
Okay, so I think it's back to me. So I'm now going to tell you what happened. Well, it turned out what she had was recurrent breast cancer with a paraneoplastic syndrome called a stiff person syndrome. You're moving on in your career. When I was in training, it was called stiff man syndrome. Anyway, now it's stiff person syndrome. The weird thing was she'd had a normal mammogram, but when I saw her, she looked really bad. And then I saw her, I can't remember, it was a month or two later, and then she looked like, my God, is she dying? What I did when I first saw her was refer her to the nutritionist. I actually believed she was taking 2,000 calories a day in contrast to her primary. There was nothing about anxiety that I sensed in her, some frustration at the diagnosis, but I felt like she needed to be believed, and that she also, part of why she had been such a healthy 74-year-old was she ate a really healthy diet. And I was having trouble convincing her that she could, loosen that a little bit. Just so we could get more calories into her and hopefully keep some weight on her or put some weight back. And I really needed the nutritionist support to get that done. So I did an urgent referral to them. When I saw her again and we went back and forth with things, then she was more debilitated. I spoke to the primary. We got her back to the neurologist, who was also shocked by how she looked. What happened was she got a PET scan and they found a little tiny node of the recurrent, what they assumed was recurrent breast cancer. Because it was COVID, because it was the latest surge over the winter, everything was taking forever. Finally got tissue, and then they could finally start treating the paraneoplastic syndrome. But in the time between sort of having the tentative diagnosis from the PET scan and getting her in as urgently as the falling apart healthcare system could do under COVID, she really declined further. And her husband, was sending these messages like, she can't walk, she can't transfer, I can't get her to the bathroom, we can't do anything. And I said, I'm going to order home care. And I'm mentioning this for a variety of reasons. First, you heard from the occupational therapist that she clearly needed help doing everything, even the basics, much less what she had been doing. And she needed nursing to monitor medicine. So pain also became a huge issue in this period of time. And it wasn't clear what she was doing. And then here's where cognition comes in. Here's where, even if you're a really healthy 74, although she hadn't been for a few months, a 74-year-old brain has a slightly different threshold. So with a whole lot of the pain medicine and the medicines for the spasms in her muscles, her brain wasn't working normally. It wasn't working as well as usual. Now that can happen to a person at any age and does in the intensive care unit or with certain intensive treatments. But your risk of having that happen to you, becoming sort of delirious or confused, goes up the older you are. And that's probably a matter of cognitive reserve. So her brain wasn't working optimally. So at that point, we needed a nurse. And the nurse was good because once I had a nurse in, I could get an occupational therapist. So there's this strange thing in home care where you can refer for nursing or PT or speech, but you can't actually get dietitian or occupational therapy unless you have one of the others. So we managed to have one. The interesting thing was that her husband, they kept trying to call, and her husband kept not calling back or saying he couldn't talk. So I get these messages from the home care agency because I filled out an urgent thing, like you need to go tomorrow. And then it's been like a week and he won't let them in. So this just goes to show they were both college educated, people, native English speakers, had done very well in the world. But health literacy is different from regular literacy. And he thought what I was sending was people to help her with everyday things like a home aide. And he had hired someone already. So he didn't think he needed that. And it was just one more thing to do. And also he was overwhelmed by a suddenly really sick wife, who used to do a lot of stuff since she retired. And now he was doing everything plus his job. So I had to explain yet again. And you also have to realize that when people are in a crisis, they don't hear things as well as you'd like. And that sometimes we think we're explaining something really well because it's something that's part of our everyday world. And maybe I hadn't explained it adequately, that you're going to need these different things. You're going to need a person to be there pretty much 24/7 to help her. And then you need trained professionals to come in to work with you all, or, the dietitian was actually via Zoom, but with the occupational therapy and the nursing. It also occurred to me at that point that we probably were going to need a social worker because he was not coping well, and there was a lot to deal with that had basically struck them out of the blue. When people, as I said earlier, when people are healthy, they tend to discount their age. And yet the risk of death starts going up in your 70s, and it goes up, and it's great to be healthy. But as we just heard, planning is key. People who plan are more likely to get what they want when critically ill or at the end of their lives. And people who don't plan are more likely to get more of what they don't want. So eventually she started getting treatment, and then she just started improving. Like week upon week, she was standing, she was sending emails again, her brain cleared. It's just been a steady progression. And then, starting the chemo, etc. Chances are it's treatable, not 100% clear yet if it's curable. But the paraneoplastic syndrome is going away too. That was causing all the neurologic symptoms and probably the intestinal symptoms too via the nervous system. We now know the nervous system and GI systems are much more linked than was thought until this century. So just improving, week upon week. Her goal was to return to a healthy state, but she was really not in a healthy state. And so one of the things we have to think about is what are healthy aging goals in an older person across illness states, and how do different professionals help? So I'm going to take you from where she was when I first saw her to where we hope to get her, and sort of show these 4 stages or 4 phases a person can be in as they age. Next slide, please. So a person may be dependent, and they may have end-stage disease. They might have a life expectancy of less than 2 years. If her breast cancer had been widely metastatic, untreatable, she would have been in this category. As it was, um, as we finally got the diagnosis, she had become almost totally dependent, and she did live in an apartment with lots of stairs. So the only way to get in and out was ambulance transfer at that point. And remember, this was a woman who was running, um, you know, earlier in the same year. The goal often becomes when a person has end stage disease and is dependent, and this isn't just for old people, this is for people of all ages, but you might move towards comfort and palliation sooner if a person has the exact same end stage disease but is 92 versus if they're 42 and they're willing to do anything to stay alive a little longer to be with their children, for example. So she began in this dependent phase. But our goal, and so we took the comfort goal, and the nurse and I and the oncologist worked on that. But at the same time, she didn't want to be dependent. So the occupational therapist and physical therapist, she ended up with both, started doing bed exercises and also showing her how to safely transfer and showing the aide, how are we going to get her in the shower to wash her, which feels so good when you don't feel well. So there were all sorts of things we did when she was sort of at this stage, even though she didn't have end stage disease. Next slide, please. So then there are people who have limited function. They usually have multiple comorbidities and their life expectancy is reduced. It's 2 to 10 years. Now there's a lot of variability there, right? Because multiple comorbidities really matters, right? You could be a person who has some high blood pressure and headaches and let's see, you're hypothyroid, and you're not walking quite as well as before. That's multiple comorbidities. But your heart and lungs and brain are pretty good. So you could live 10 years, you know, if you're not walking very well, you may well die of a fall. The goal there, and this is where healthy aging, I think, comes in. So in traditional medicine and geriatrics, you look at a person with limited function and multiple comorbidities and probably a reduced life expectancy, because it's actually really interesting. If you look at graphs of people, whether they're 75 or 85, and you look at the people in the bottom 25% for function and the top 25%, there can be a 10-year difference in how long they'll live. So a 75-year-old who's pretty sick will live a shorter period of time than a healthy 85-year-old in many cases. So the goal here, you know, when she got a little bit better initially, she had this limited function. And in some ways she did have multiple comorbidities because she had the cancer and she had all kinds of neurologic and weakness, you know, and gait challenges from the paraneoplastic syndrome. And one could argue that her life expectancy may be 2 to 10 years, depending on how her cancer responds to the immunotherapy and other things. So if a person is very old and they've already declined considerably, and particularly if they're in a lot of pain, or they're also having trouble seeing or hearing, or they have dementia, the goal can be preserving function because it always feels better. There's not an age at which you feel really happy if you have to use a diaper, or you can't walk yourself to the bathroom or make your own lunch. That just doesn't feel good. So we aim on preserving function, but I think this is inadequately ambitious, that we could look at people like this and say, I wonder if we are guilty of typical aging here. I have seen this so many times with patients where, you know, you send them off to physical therapy after they've been ill and you'll get a note like discharged, walking well with walker. And I think to myself, my God, they didn't have a walker before. Like, oh, getting them to a walker is not the goal. You know, that's their worst case scenario. It's great that they can walk a bit, but we need to get them back to walking as independently as possible. So it's not about preserving where you are. It's about thinking, who are you? How much do you want to do? How hard are you willing to work at it? Because, you know, we all know at all levels, if you want to stay fit, you have to work at it. And it's a little harder as we get older. But actually the study, or one of the studies that made me a geriatrician, was in the New England Journal in the mid-90s. And somebody took people in a nursing home. So like really old, really frail, people in their 80s or 90s, and had them, gave them good nutrition with protein in it, and had them do regular resistance exercise, so weightlifting. And people walked upstairs who hadn't done that in years. People who used walkers used canes. People were able to go much farther. Their self-confidence increased. They started doing more things socially. We don't try hard enough. We don't believe in the capacity of older people, and sometimes they don't either. So yes, our patient Patricia had this phase of limited function, but at least with her, we knew that the goal was to make her more than that. I just think too often we write people off when we shouldn't and don't need to. Next slide, please. Then you get people who function really well, like this guy. He's fit, he's doing his sit-ups, he should be doing planks, maybe he hasn't heard, we've switched to them anyway, or maybe he's just stretching out his back, because the spine can get really tense also as you age. He's got multiple comorbidities, but none of them really impair his function, right? So maybe he's taken something for blood pressure and something for high cholesterol. Maybe he's got some arthritis, but basically he's doing well. Life expectancy 8 to 14 years. Now the range is there because it really depends on what his conditions are. If he has diabetes and has had for many years, it's probably going to be on the lower end of the 8 to 14, particularly if it's not well controlled. But if he doesn't have diabetes, if he just has the things I described, he could go for 14 years. His goal is to maximize function. Like, he wants to be as functional as he can be. And here is a good moment to really intervene with healthy aging. Like, maybe you actually have never been an athlete in your life and you might want to be now. Or maybe you just never had the time or the energy balancing family and work and just everything else that life requires of you. And now is a moment where we can really get you fit and functioning. Is there some sport you always wanted to do? Would you like to see your abs looking pretty amazing? What's this guy's goal? We talk to him, we ask, and we think big and push hard if that's what the person wants. Next slide, please. And then there's a person who's highly independent. I like the picture of this guy, running speed races, and I believe he was also a marathoner. But you can see he's probably smaller than he was when he was younger. When you're in your 80s, you're smaller. My own mother is 88, and I call her the Incredible Shrinking Mother because I can now see clear over her head. People get smaller. Doesn't mean they've lost function. He is healthy, doesn't really have any problems. He doesn't even have arthritis. His life expectancy 12 to 40 years. Now, 12 to 40 years is if you're, if he's in his 80s, he's not going to live 40 years. But if you're seeing an older person who's, 64, and that seems old to you, they might well live 40 years if they're this healthy. And the goal for this sort of person is often longevity. And they can also withstand many more different types of treatment. Now, this is who Patricia was before her big decline. Can we get her back to this? I'm still not sure. It's only been a couple of months of treatment. We can certainly get her back to the category before this, but we may well get her back to healthy. Do I think her life expectancy will be shortened by what happened over the last year? I do. To lose that much muscle as an older person, to undergo the various treatments she's had, which have included lots of steroids and more chemo. That's a lot, and it's going to be harder on her than it was in 2008 when she first had her cancer treatment. So I do think she'll lose some life expectancy, but she may still have the goal of longevity given her current limits. She may still want to be healthy, particularly if the chemotherapy works. She certainly still wants to be independent, and she'd love to start seriously exercising again. Fortunately, the PT and OT have her doing weights at this point. She's going up and down the steps. She has made huge progress with them and is starting to take on more of the household tasks again. There is also sort of like a PTSD element to all this for people. So lots of goals. She is putting back on weight. She is sleeping better. She's requiring fewer medicines. Her cognition has cleared, but now we know she has a little vulnerability there, and her father did have dementia. So it's something I'm going to keep my eye on, because it might be if she had a perfectly normal brain, she could have taken all those medicines, even at age 74, and not become a little bit confused. But that wasn't what happened. So I'm going to keep an eye on her. I think at this point, we move on to the group exercise. And so I'll just say that in situations like this one, it is absolutely essential to have a team. I know some more about nutrition, I think, than the average physician, but I don't know what a nutritionist knows, nor do I have the time. I don't have the time or the expertise. Certainly, I can't be a PT or an OT or a social worker. And this family required, given how much education they have and being native English speakers, I was shocked by how much help they had. They needed, how little planning they'd done, how they needed help coordinating everything, how they did not have their affairs in order as they thought they did. It was the financial side, not the health side, as we see not infrequently. So there's so many ways in which a team, each member of the team makes all of us better. And then I also want to just end by saying, if the whole team can be in conversation with each other, it's much more efficient and it's better for the patient. And for those of you who are going to be physicians, I often find the physicians are willing to have conversations with other physicians, but not with the whole team. Don't be that person. You're going to provide better patient care if the entire team, and that may well include the patient and caregiver, are on the team and in every meeting and on every email. And with that, I will turn it over.
Thank you so much, Louise. I'm glad you mentioned that. We try to have a patient or a patient's caregiver present. We weren't able to secure that this time, but that patient point of view is really, really important. I wanted to let everyone know, to give you kind of ground rules for what's next, is our small breakout group facilitated discussion. In the chat box, I've uploaded the Eldercare Grand Rounds Facilitator Guide so that you have access to it. Make sure you download it before I hit open up all rooms. That way you have it easily accessible. I know facilitators already have a copy, but it's always nice for some of the students to have one too, just in case something goes wrong with screen share or whatever might happen with technology. I'm going to open up the breakout rooms. They're going to be open for 15 minutes and then they will automatically close and bring you all back to the main group. That way we have time for some large group debrief in addition to some Q&A with the panelists. You've already been entered into rooms. If you did not register, there were a few people that I checked in on to see whether or not they were registered. You might be left in the main room. Spencer will get you assigned, so don't worry if you aren't registered. Spencer's going to be in the main room helping out anybody that falls in that category. Without further ado, though, I see I'm going to make sure we have multiple people can share the screens so that the facilitators can share screens when they get into their breakout rooms. And you all should have what you need. So I'm going to go ahead and open up the rooms and I'll see you all there and we'll be back here in 15 minutes. All right, welcome back, everyone. I see folks joining us and getting back in. And I think, Spencer, you can advance to the next slide, and we're going to turn it over to Brittany for our large group debrief.
All right. So we talked about in small groups, we talked a little bit about what some of these interprofessional roles might look like. But as a larger group, what are some of the disciplines that you were exposed to today that was maybe your first time hearing about it? Or maybe it was your first time hearing the details of that discipline. Is there anybody who would like to share by either unmuting or writing in chat? What was a new discipline or area of a discipline that you were exposed to today?
Hi, my name is Simi, and I think one of the discipline that was new to me that had like details that I was interested in was the occupational therapist. During my clinicals, I had many patients who would have OT orders, and I didn't know what that was. And I also kind of like thought it was like interrelated with physical therapy. So just getting to hear the information about how they are and what they do with elderly patients was good. Thank you.
Thank you. I'm sure Lindsay has heard that before. It's sort of a common thing where people don't really know what occupational therapy is or how it might be different from physical therapy, including a lot of physicians themselves.
That's why we do this. Thank you for sharing. It warms my heart when I hear these things during grand rounds.
Is there anyone else who would like to share either a new discipline or an aspect of that discipline that was new information for you today?
It looks like Melissa said I hadn't heard of whammy. Would somebody like to explain what whammy is?
Whammy is a no, go ahead. Ari, you got this.
WWAMI is a consortium of states that kind of connect to make a regional medical school. So it's sort of all housed within the University of Washington, but then there's campuses in Washington, Wyoming, Alaska, so us, Montana, and Idaho.
Thank you. And I also see in the chat social work from Marina. She said she didn't really think about how social work would apply to geriatrics. Usually she thinks about social work in the vein of children and family. So it was great for her to consider how they can be beneficial to elderly populations. Excellent. Thank you for sharing, Marina.
Yes, thank you. And maybe Amanda can help me out here with this, but I had read some recent statistics that up to 75% of social workers will work with geriatric cases and older adults. They often don't have a lot of training in it, but most social workers end up doing something with geriatrics, unless I'm incorrect on that, Amanda.
Yeah, I mean, I think so. And I think what I always talk with my students about is that as social workers, you end up working with families so often, and those families are multi-generational. And so we don't ever want to say, oh, I don't work with this population, or I don't work, because you will. And so, again, looking at, what specialty we're in, where we're working, what agency we're in, of course, we have to learn that specialty. But it's important to be familiar with sort of comprehensive, assessment, plan of care, and, quality of life issues around aging as well, I think. And I see that Catherine mentioned, she didn't realize that social workers do help with estate planning and living wills. And I think I facilitated, power of attorney, living will paperwork many a time. And I think it's really important for us to help families deal with legal, obviously not giving legal advice or anything like that, but just providing the paperwork, providing support around it, conversations around it, because it can be really difficult to make those decisions, to put the forms in place, the power of attorney in place, whether you need a guardianship or something for a loved one as well. So just to be able to support folks through all of life's endeavors.
Okay, Ella says, I appreciated hearing from the dental hygienists and how teeth, oral health, infection and disease prevention can also support dietary issues. I would say that is such a great point. It was a takeaway from my own group. I had a lot of dental hygienists and future dental hygienists in my group, and they were really clear about the ways that they could really round out an interprofessional team, but maybe are often left out of interprofessional teams. So another comment I'm seeing here, when I was working in the ER, majority of our social work consults were for geriatric patients. From my perspectives, a lot of times it's because this population hasn't been put into much consideration with different care or what that care is. So it was a lot of helping patients get the care that was set up and pulling OT into the care team. Excellent. Very, very insightful comments, folks. Here's another one from Rachel. The importance of occupational therapy as an elder is important for quality of life and feeling of purpose. Absolutely.
I brought this up in our small group, but I really appreciated hearing how the nutritionist has the luxury to spend a ton of time with the patient and collecting a really detailed history, which is so valuable. And so I did not know that, and I really appreciated hearing about that.
Thank you, Christina. Amy, you did mention that you like to take a lot of time with your patients. Is that the sort of thing that you always get the luxury for?
Not necessarily, but one thing that, and it's different for everybody, but one thing that I try to tell my students is that, I think a lot of times students want to spend all their time in that intervention and education and treatment, when I really feel like, as dietitians at least, if we spend 75% of the time, whether that's 15 minutes or an hour, in doing an interview and just listening and asking open-ended questions, you really just get so much information, and what that intervention and education should actually be will be very apparent, and so we're providing what our patients actually want or need, or but yeah, I think, but compared to other providers, dietitians, even in the hospital when they don't have a really long period of time, can have a lot more than others. So we just need to communicate.
Thank you. What a great point, though, that intake and assessment are often given such short shrift, but is really where we get the crux of our information and get to spend time with people. Another comment in the chat, not necessarily specific about the teams, but our group really enjoyed how the different disciplines were patient-centered in their goals and with the willingness to learn. Absolutely. I think that's one of the major components of an interprofessional team, is the teamwork and the communication, and thinking about different ways to be patient-centered. So I'm going to move on to the next question here. We've already been getting into that a little bit, but what are some of the other takeaways from this event that you think you might be able to utilize once you're out practicing in the world?
So this is Lisa, and I appreciated that in our group, somebody brought up taking care of the caregiver and respite care, to make sure that in this particular case, Patricia's husband was getting the resources he needed, which our provider, the gerontologist, did pick up on as well.
Yes. Yes, thank you.
We had that same takeaway in our group. And then we also talked a little bit about the self-care of the providers. And I was really pleased to hear that the clinical psych department is practicing self-care plans with their future providers. So they're already getting that head start. And I can't stress enough, if we've learned anything from this pandemic, it's the value of self-care of our providers, that provider resiliency, and really shifting the culture of what it looks like in healthcare to be more promoting and supportive of self-care. So I leave that with you all as future providers, so that you can help shift that culture when you go into practice, because it is so important.
Yes, thank you. Any other takeaways?
So in our group, we talked about recognizing the limits of our own care and being knowledgeable of the resources that exist, so we know when to when our care ends and when someone else is better qualified to provide the care, and kind of pass that on as a resource. And even if, not to push these patients off necessarily, but let them know that they have options and present the options to them and respect patient autonomy. We also talked about how approaching things in like a team aspect, right? You get a lot of different perspectives to handle this problem. But you also get a lot of people with different walks of life who have different ages, different backgrounds. And sometimes these patients can better resonate with a social worker or with a nutritionist than a physician or a nurse. And it's very important to, get them connected with people of different walks of life.
Yes, thank you. So I heard it's important to stay within your scope of practice and to know what your role is, and to work with other people who are specialists in other things, that teamwork and the collaboration can help solve a puzzle. That was a term my team used, talking about how we all can't know everything. And in Patricia's case study, her original physician had some misdiagnoses. It was anxiety and it was eating disorder, and those were not really the issue here. And so once an interdisciplinary team came together and sort of took apart that puzzle and put it back together, it looked very different. So people in the chat are commenting as well. You can't pour from an empty cup in relation to the self-care issue, which is so super important. Thank you, thank you, thank you. Any final takeaways before we move it on to Q&A with our panelists?
I think it was maybe mentioned first with the occupational therapy presentation, where she said, occupational therapy, aging adults might say, oh, I don't have a job anymore, but recognizing what people want out of life, or your purpose in life throughout all stages of the lifespan. And I think I like how within the interprofessional team, everybody has this opportunity to be able to find that out for the patient, because I think as healthcare providers, we're always, going to be a little tunnel vision to the specific health problems, like your potassium levels off or whatever. But we're not just trying to keep a body alive, we're trying to keep a person vitally alive. And so being able to work together to really key into what those values are for that individual, especially as people age, they can just feel like they were put on the bookshelf of life and sort of forgotten about, and maybe they don't have that purpose anymore. And so really working with them to keep that alive. In Japanese culture, I believe there's a word, it's ikigai, which means I think it means like the reason for being. And there's actually a lot of like a higher population of centenarians in this one region of Japan, and it's because this is like part of the culture that they keep this in mind. And I think we lose that a lot. Sorry, I'm very passionate about geriatrics, and so I think we lose focus of that in our care of our elder populations. And so just maintaining that approach, like within, and remembering that as we work together as a team, we're not each just trying to solve our one little problem, we're trying to take care of a human well.
Oh, thank you so much, Noelle. That is really well put, as everybody is mentioning in the chat. It actually reminds me of something, if I can turn to Dr. Aronson real quick here, and maybe you can advance the next slide. Something I read in your book, Dr. Aronson, called Elderhood, was about your own medical training. And I'm wondering if you can just tell us very briefly how these conversations with these students right now may seem different or similar to the sorts of training that you had when you were in medical school.
Sorry, was muted. Well, I had very little I think it's better. I don't think it's good. I mean, we were just discussing across the professions. You quoted about social workers that 75% will deal with it, older patients. It's similar in physical therapy and occupational therapy, unless you're specifically focused on kids or pregnant women or, you know, post-sporting injury or something. And yet it's kind of the same across the professions. In medicine now, you get days to weeks of training in older adults, you get months of training in kids, and you get years of training in adults. And it's probably like so many things with race and gender in our society that it was built in the image of the people building it. And so, you know, it does kids an injustice, and it does older people an injustice, especially since you consider that old age is the age where people on average have the greatest health needs. And people will say, oh yeah, you know, the older people are just eating up the healthcare dollar. Well, when did you last hear somebody say, oh my God, do you know that it's like 98% of the education dollar is spent on children? I mean, you know, we have different needs at different life stages. You also don't hear about the military budget being entirely adults, or you know, there are all these things that happen. And we blame older adults for their needs in ways we don't blame others. So I still don't think we're hearing, you know, is there more? Am I super psyched that you're doing this? Absolutely. I don't remember having anything like this in my training. And actually, I became a geriatrician. I was going to be an internist, because in caring for my patients as a resident, I found that I was not only not meeting their needs, I was actually harming them at times. And I was at supposedly the best training program in the country. And I was being taught to harm them because I was treating everybody like they were 40. And that just made me, I mean, I feel like Noelle, now I'm getting all passionate. But yeah, that made me crazy. Like, I didn't become a doctor to kill people and harm them, like absolutely not. And I also was really interested in underserved populations, and I realized there was an entire population segment that was underserved. And then I just want to add to that we forget intersectionality, because as with COVID, you hear brown and black people suffered more, which absolutely is true, and old people suffered more. But who suffered the most? The old people who were brown and black. And we act as if those things are mutually exclusive. So there's so many ways. It's so cool right now in elder care, because it's a booming population and there's so much you can do. So hopefully we're getting people psyched.
Excellent. Thank you so much. Does anybody else have any questions for our panelists?
I do have a question, sort of more of a concern with my training. So I'm a medical student, and we focus a lot on problems individually, sort of what you're saying about like how like the intersectionalities of different demographics, they're seen as mutually exclusive. I feel like a lot of problems like renal failure and arthritis, they're mutually exclusive, but often happen on top of other problems. And I just see it a lot. And the issues with polypharmacy, and just kind of this void of physicians who like really are overwhelmed by taking care of patients with multiple conditions. And I just wonder if there's any advice or guidance that you could provide as to like really focus our training on being better at that.
So my answer to that is all of us are overwhelmed and feel inadequate when we're asked to do something we're not trained to do. You know, I don't feel overwhelmed and inadequate when somebody has polypharmacy and multimorbidity, because I did this training to learn how to do it. So I think, you know, and it's also a bit of ageism that, you know, like if I suddenly go into, I don't know, the ICU where I haven't practiced in years, I'm going to be pretty incompetent. And everybody will recognize like I need training in ICU medicine to do that well. But when people do harms to older people or feel overwhelmed by them, what happens instead? They say, oh, I just don't like taking care of older patients. It just doesn't feel good. And they don't apply the same standard of like everybody deserves that care. So, find people who are experts in multimorbidity or polypharmacy, read about it, think about it. That was actually how I started as a general internist, was like, oh my God, I'm hurting people. Where can I go? What conferences can I go to? Who can I speak to that can make me better? It's also a great time to include the interprofessional team, because you want to know about polypharmacy, ask a pharmacist. You want to know how to cope with problems that have functional things, speak to your OT or your social worker. It's one of those times where if you look around, it's a shame you have to do it for yourself, that the system won't do it for you yet, but also keep demanding that the system be better. It's better now than it was, and it's just going to have to change if we're not going to, keep doing harms. But the fact that you're thinking about it already and asking is a really good sign for you as a clinician. It's that kind of sort of open-mindedness and humility means that you'll keep learning and you'll keep trying to fill the gaps in your training. It's a great sign.
Excellent. Thank you. We have time for one final question, if anybody has one.
If nobody has anything else to say, I'll ask one more question. I know I've read Being Mortal by Atul Gawande, which I think addresses this topic very well. But also, like, what are other resources that anyone has to suggest just for caring for our aging populations and hopefully doing it better than our system as a whole in America does right now?
So this is Amy, the dietitian. One thing that I always encourage, regardless of what your discipline is if it's possible to spend a little bit of time, shadowing or working with, or just, interviewing, being a part of another discipline. When I worked in the hospital for a long time doing inpatient diabetes care, I invited residents to come walk with me for a half a day and just to see a different perspective. And so that's a resource, is that it's great. Go hang out with an OT for a little bit, just be a fly on the wall, and you'll learn so much just from hanging out with somebody for a little while.
Thanks for that, Amy. There's also some notes in the chat as well, some resources that you can take a look at. Dr. Aronson's got some books that you could take a look at. And I also wanted to let everyone know, I posted a survey for today's event in the chat box, so please take some time to do that. There was a question about certificates, so just for some housekeeping, I will be having those certificates sent out before the end of next week. If you did not register, I think I got most people on here, but if you, for any reason, don't receive a certificate, it might be because you weren't registered. Just shoot us an email. It's uaa_ahec@alaska.edu, and we'll make sure we get that to you. I'm putting it in the chat as well.
Great. Thanks so much, Gloria. Spencer, could you advance one more slide? And I'm going to turn it over to Amy to tell us about one more cool upcoming event.
So I'm so excited that you put this slide in here. I should have thought about it before. But so for those of you that really enjoyed today and do want to get a little more practice working with an interdisciplinary team, we are offering the weeks of April 4th and actually April 11th, I think. There's 3 days each week, each of those weeks. We're offering an interprofessional simulation, working with the case of Pat Jones, which is a 70-year-old male, female, we're not sure yet which, but that has a variety of different circumstances, different things going on. And essentially you would work with participate in the simulation working with the interdisciplinary team. So there will be students from a variety of different programs. You'll have dietetic students, pharmacy students, social work students, nursing students, provider students, and you are going to interview this patient and come up with a care plan and get a chance to actually practice some of these things that we talked about today. The registration link is right there, and it's from 3 to 5 on a variety of days. So you just pick whatever is going to work best for you. And I really encourage you to do it. You can, during the simulation, you can participate as much or as little as you want. So if you're not super jazzed about the idea of being the one to interview the patient, you can just be a part of the team and listen and learn from other students and what's going on. So join us. It'll be super fun.
Amy, do you have to be there for all the sessions, or can you just come to whatever you can make it to?
Yeah, you just actually go to one
session.
Yep, it's
okay.
one 2-hour session.
Gotcha.
Yep. And so we are making it so hopefully each of the sessions has an interdisciplinary focus. And yeah, so just one.
Thanks, Amy. And then everyone on here who is an AHEC scholar, if you do attend one of those sessions, that would be 2 hours of community-based experiential learning that would count towards your requirements. So keep that in mind when you're considering whether or not to attend. Brittany, you want to wrap it up, or do you want me to take it from here?
That is all I had.
Yeah, I figured it was. So we are going to be picking a new topic for next year's grand rounds. If anybody has any suggestions, please include them in your evaluation. We always love student suggestions for our topic, and that topic carries through the whole year for our grand round events and also for the Interprofessional Team Care Conference. So feel free, if you have any really passion areas that you want us to explore with this type of a format, to put that suggestion in your evaluation in the comment section. We really appreciate all of your attendance and participation, and we look forward to next year where we'll be able to provide more grand rounds events. So thank you so much, and have a great rest of your day and a great weekend.